Are you able to see?
Yes, sir.
The screen visible? Okay.
Yes, sir.
The brachial plexus is formed by the anterior primary rami of spinal nerve T5 to T1. Okay. So as soon as they come out as roots, they immediately join to form the trunks, upper, middle, and lower trunk. Then they immediately divide into anterior and posterior. All the posterior divisions form the posterior cord, and the upper two form the lateral, and the lower one forms the medial. And from there they give off the branches which are called the terminal branches. Sometimes we may get a additional supply from C4 or C2. That is called the pre-fixation and post-fixation, and they don't make much of a contribution to that. So all the roots will be only from the C5 to P1. And so this is how the drawing you have to make in your answer paper, so that you can easily remember that. And so roots, trunks, divisions, cords, and branches. And the terminal branches are musculocutaneous, axillary, median, radial, and ulnar. So all these nerves are formed. And this is the anatomical picture. You can see the actual other structures also, uh, forming the roots, trunks, and divisions and cords. And finally, at the axillary level, you get the terminal branches. So there are 5 roots, 3 trunks, 6 divisions, 3 cords, and 5 terminal branches. These numbers you have to remember as a total formation. And so at the root level, you have 3 branches coming in. One is called the dorsal scapular nerve, long thoracic nerve, and intercostal nerve. At the trunk level, which is at the posterior triangle of the neck, traveling between the anterior and middle scalene muscle behind the subclavian artery. This is the relationship. And from the trunk level, you get the superior trunk gives rise to another couple of nerves called the suprascapular and subclavius nerve, subclavius. And the trunks reach the posterior aspect of the middle third of the clavicle. The 3 trunks divide into anterior and posterior divisions because they form the cords, and these are all the things which are normally known to all of you. So the posterior cord is formed by the posterior division, the lateral cord by the 2 anterior, and medial cord continues as the division of the inferior. And the cords are placed around the axillary artery. That is the reason for their name also. So if it is medial to the axillary artery, it is a medial cord. If it is lateral to the axillary artery, lateral, and if it is posterior to the axillary artery, it is called the posterior cord. And the lateral and medial cords innervate the muscles of the anterior compartment of the forearm, and posterior cord innervates the extensor or the flexor. The flexor and extensors are supplied by the 3 cords. So the lateral and medial cord mainly supply the flexors and or the anterior compartment muscles, and posterior cord supplies the extensors of the forearm. And that is the reason why you do that flexing, extension, all these things to identify the terminal branches. And the branches given by the terminal, before the terminal branches, lateral cord gives what is called the lateral pectoral nerve. Posterior cord gives rise to the upper subscapular, thoracodorsal, and lower subscapular nerve. And medial cord gives rise to medial pectoral, medial cutaneous, and medial cutaneous nerve of arm. And the lateral cord ends as the musculocutaneous and lateral root of median. Posterior gives rise to radial nerve and axillary nerve. Medial gives rise to ulnar and medial root of median. Now the supraclavicular branches, you can divide the branches also into supraclavicular and infraclavicular. The dorsal scapular arises directly from T5 spinal nerve. And this is the reason why sometimes when you try for a supraclavicular block and when you try to elicit paresthesia, patient may be telling that it is hurting at the back. You will not say it is hurting or the shock-like sensation at the elbow or the hand. You will say it is hurting at the back. That means you are tickling the dorsoscapular nerve. So you have to redirect the needle to get a successful block, and it gives the motor innervation to levator scapulae, rhomboid muscle, and rhomboid minor muscle. It also gives that sensation of pain in the scapular region. And the suprascapular nerves emerge from trunks of C5 to C6, and they give the sensory innervation to humerus and acromioclavicular joint pain also is caused by that. And they supply the supraspinatus and infraspinatus muscle. The long thoracic nerve, which arises from the nerve of C5, C6, C7. These root values are always often asked, so that is an important thing you have to remember. And the subclavian nerve emerges from the superior trunk and contains fibers from C5, C6 root and provides motor innervation to the muscle called subclavius muscle. The lateral pectoral nerve of the lateral cord arises from the lateral cord, and that has the root value of C5, C6, and C7. And the medial pectoral nerves, they anastomose together lateral nerves to participate in the innervation of pectoralis minor muscle. And the lateral root of median nerve, which is a short branch, is one of the two roots of median nerve. So median nerve has two roots, one from the lateral cord and one from the medial cord to form the final median nerve. So musculocutaneous nerve is the terminal branch of lateral cord, and that gives fibers to contain C5, C7. So all the root value is important when you deal with a patient with brachial plexus injury. So depending upon the number of roots involved, there may be a total paralysis of all the 5 roots. That means the limb will be totally flayed. You will not have any action. Sometimes it may be a partial injury which will affect the upper 2 roots like C5, C6, or the size C7 alone, or C7, 8 and T1. So you should be able to identify which exact roots are there. So this is the, unless you know the anatomy of these various motor branches supplying the various muscles, you cannot identify the level of injury of the brachial plexus. And the motor fibers of the musculocutaneous, they are important for supply for biceps, thoracobrachialis and brachialis. So that is why if musculocutaneous nerve C6, C5 and C7 is paralyzed, patient will not be able to flex the elbow or bend the elbow. That is the way you find out the injury. More commonly after a two-wheeler accident, high-speed motor vehicle accident, you find the brachial plexus injury happening. So if the patient has failure of elbow flexion, that is the roots affected are from C5, C6 and C7. And the sensory branches, they supply the skin over the lateral surface of the forearm via the lateral nerve of the forearm. So the thumb side, the radial side will not be able to, will not have a block. So patient will complain of pain when you make an incision on the radial side, but he may be very comfortable when the incision is made on the lateral or mid portion of the forearm. So that is the way again you find out whether the lesion has occurred there. And medial pectoral, so all these things are various levels of supply which are given here. Can go through that literature to identify various supply to the various muscles and the sensation. And this knowledge, as I said, is important to identify the level of lesion in the brachial plexus. And the subscapular upper and lower, they are also supplying the other muscles like subscapularis, teres major, and lower. The thoracodorsal nerve supplies the fibers which has the root value is C7 and T8, and it supplies the latissimus dorsi muscle. So mainly the latissimus dorsi muscle will be. So how will you identify whether the thoracodorsal is injured or not? what will happen to the scapula? Okay, you try to tell me. So there are a lot of mnemonics to remember all these things. So to remember the uh, rugby team don't cover bruises. So this is the root, trunk, divisions, stalks, and branches. That is remembered by the mnemonic. Rugby teams don't cover bruises. And for the branches of the lateral cord, rugby players, long leg movers. So LLM, the capital that is given is lateral pectoral nerve, lateral root of median and musculocutaneous. For medial, you have 4 M's and 1 U. So during my undergraduate days, I was taught money makes many men unhappy. That was the mnemonic that I learned. But here it is given make many moves using muscles. So the 4M stands for medial cutaneous nerve of the arm and the forearm, medial pectoral, medial root of median, and ulnar nerve. These are the branches of medial cord. For the posterior, you remember ultra, which is the same mnemonic which we were also taught. Ultra stands for upper scapular, subscapular, lower subscapular, thoracodorsal, radial, and axillary. And all the nerve regions they produce the mnemonic is Dr. Kuma, standing for if it is a radial nerve injury, you will have a wrist drop wrist. If it is a ulnar nerve, you will have a clawed hand, E. And if it is a median nerve, you will have a eighth hand. So these are the lesions that you will find if the motor innervation is affected by the radial, median, and ulnar. Radial wrist drop, ulnar claw hand, and median eighth hand. And the various approaches at the root level, you have the interscalene block. At the trunk level, you have what is called the subclavian perivascular. So even though interscalene is given higher up at the interscalene groove, at the level of the external jugular vein, the subclavian perivascular is given at a lower level. The same interscalene groove, when it comes closer to the clavicle, it forms a nice triangle. And there you have the trunks placed close to each other in an enclosed space. So that is called the subclavian perivascular approach. At the division level, you have the classical supraclavicular. And at the cord level, which is usually at the intraclavicular, you have two approaches. One is called the intraclavicular and costoclavicular. And at the branches level, it is called the axillary block, which aims to block the terminal branches. So all the 5 levels you can block. And this is the picture to show you. So interscalene at the root level itself, you can go that to the higher interscalene level of the groove. Subclavian perivascular will be very close to the uh, lower end of the interscalene groove, where you can palpate the subclavian artery pulsation also by putting your finger deep behind the middle end of clavicle. You can palpate the subclavian artery, and then you can blindly go above the artery and deposit there because it's a nice enclosed space. The drug will nicely block even if you don't get a paresthesia or even if you don't have ultrasound, you can easily block the brachial plexus there. So the indications and the disadvantages, as we all know, interscalene is mainly for shoulder and upper arm elbow surgery. It is not recommended for hand because the lower trunk usually gets spared. But in overcome this problem, if you increase the volume, it will also travel down and block the lower trunk also. But unfortunately, what will happen when you increase, definitely the phrenic nerve hemidiaphragm. And patients who are healthy, you will not notice any difference because the other diaphragm can compensate. On the contrary, patients who have a respiratory like say you are asthmatic or COPD, they will definitely have some difficulty in breathing. So, uh, giving a higher volume can produce a block of the lower trunk also, but at the same time, will definitely cause some chronic nerve palsy. You have to remember. So, and a misguided needle in the intracranial approach can produce pneumothorax, direct damage to the nerve, epidural or intrathecal placement of the drug, spinal cord trauma, bleeding, and hematoma. So all these things are possible with intracranial unless you are quite careful with that. And phrenic nerve also can be affected with the volume of anesthetic by giving. If you give a lesser volume, the chances of phrenic nerve block are less. But if you give a higher volume, definitely that will happen. And subclavian perivascular is the block aimed to block the three trunks. So to overcome this deficiency of intracranial block, subclavian perivascular was described, and that blocks all the three trunks, upper, middle, and lower trunk, as they cross the first rib. And this is indicated for humeral, elbow, forearm, and hand surgery, especially areas supplied by the median and radial nerve, and lateral and posterior cutaneous nerve for the forearm. And the complications of this are again pneumothorax, fixing of ulnar and intercostal brachial, ulnar syndrome, phrenic nerve palsy, and rarely block failure also is one of the complications. The supraclavicular block, because all of you would have been used to this, the primary regional anesthesia for surgeries and also for post-op pain relief it is given, and it is mainly for the distal two-thirds of the upper extremity. So supraclavicular approach is not good for shoulder surgery. So shoulder, either you have to go for interscalene on subclavian perivascular, and all the general complications which are described above are all common with this block also. And it can produce hoarseness due to epilateral laryngeal nerve block, Horner syndrome, etc. And stellate ganglion block is also possible. And that will result in vasodilatation and very prominent vasculature, venous engorgement. And phrenic nerve blockade is also possible with the supraclavicular approach. Coming to the intraclavicular approaches, you have this technique. This was described. You know who described this? First described this intraclavicular nerve block. No idea.
No, sir.
It's one
No,
of
sir.
our Indian. He was called Prithviraj. Short form, he was called Raj. But his full name is Prithviraj. He is Rajasthani person who went and settled down in first USA and then went to migrated to Canada. And he has written a nice textbook on various blocks for the upper limb. And he had been to Chennai also for one of our meetings in State of Anesthesia. So it is called the block described by Mr. Raj, Dr. Raj, Raj is his full name. And he described this intraclavicular block mainly because all the cards are very close to each other to the axillary artery. And this is supposed to be the incidence of pneumothorax is supposed to be less with intraclavicular. That is the main idea. Second idea was you can place a catheter for continuous pain relief, especially after amputations and other things to remove the phantom limb pain. You prescribe this or you describe this particular block. And it also gives a provides good tourniquet control. Whereas with other types of block, you have to block the intercostobrachial at the arm level to make the patient tolerate the tourniquet pain. Whereas intraclavicular produces a good tourniquet tolerance also. And the plexus is located deep to the clavicle, and so you need a longer needle to block this. So your classical intramuscular needles which you use for the other locations may not be suitable for this particular technique. And if you are using a ultrasound, you have to use a small curved ultrasound probe because the area where you place is very narrow. So you require a small curved ultrasound probe rather than the regular linear probe that you use. Coming to the costoclavicular, it is a well-defined space at the intramuscular level, lying deep and posterior to the mid part of the clavicle. And the muscles which form that space are the clavicular head of pectoralis major and subclavius anteriorly, and serratus anterior and secondary posterior. So these are the anatomical structures which form the costoclavicular space. And all the three cards lie the sonogram, you will see they are clustered together. So unlike the infraclavicular where they are located in the classical lateral median and posterior position, if you see the ultrasound picture of the costoclavicular, you will see all the cards are lying lateral to the axillary artery and exhibit a consistent triangular arrangement. That is the advantage of this costoclavicular. And the block needle can be inserted into the center of the plexus with minimal discomfort to the patient compared to the infraclavicular where you have to go through both the muscles. This involves lesser pain to the patient. And the low dose of local anesthetic and single injection provide very good effective analgesia. That is why this block has become more popular compared to infraclavicular. Now coming to the last approach, which is called the axillary block, for its safety and suitability. And the advantages are avoiding phrenic nerve and pneumothorax. These are the two important complications that are avoided by axillary nerve. But the other risks are, and it is quite easy to do, because all the nerves are quite superficial and you can always palpate the axillary artery pulsation, the axilla. Learning and executing the block is very easy. And superficial location makes it also easily visualized. As I told you, you can see the dancing needles. If you don't have an ultrasound also, you can easily view it with a successful success rate. The disadvantages are usually the musculocutaneous can be spared if you don't give an adequate volume or if you don't feed the local anesthetic upward towards the coracoid process after injecting at the lower part of the axilla. Musculocutaneous may be spared, which will result in patient will be able to flex their elbow and also will have sensation over the lateral border of the forearm. And incomplete anesthesia is also quite possible. The block is not replaced. So usually they advocate two needles, one above the axillary artery pulsation and one below. But if you are within the space, giving a larger volume of 30 to 35 ml will definitely block all the nerves. And inadvertent intravascular injection, both which I described in detail. And in obese patients, it may be challenging to palpate the vessel and do the positioning. Even ultrasound may not give you a good picture. Now, coming to the adjuvants that you add to local anesthetic drugs, can be classified into opioid and non-opioid. Can broadly divide them into opioids and initially it was the opioids which were added to prolong the duration of the block for post-op pain relief, whereas the other drugs, non-opioid drugs which came later on, they were also found to have a similar effect of prolonging the block without the complication of respiratory depression introduced possible by opioid. So that is the reason why other drugs were started being used. And the non-opioids, as she rightly said, it can be a vasoconstrictor in the form of epinephrine, or what is the other alternative for epinephrine?
Adrenaline.
Adrenaline is only epinephrine.
Ephedrine.
Ephedrine is not added. It should be a strict vasoconstrictor without any central effect. If you add ephedrine, you will have tachycardia also because it will stimulate the heart. Phenylephrine can be added. Okay? Phenylephrine has the alternate for adrenaline or epinephrine. Nowadays we use alpha 2 agonists like clonidine and dexmedetomidine. You can use anti-inflammatory agents like dexamethasone. You can use acetylcholine inhibitors like neostigmine, dinosine, ketorolac, midazolam, magnesium, and sodium bicarbonate. I have not added buprenorphine because buprenorphine is not given in the classical techniques. Even though in practice we are using buprenorphine very commonly, none of the textbooks are including buprenorphine. So under opioids, it is the fentanyl or 2-fentanyl, which have a more lipophilic action, and morphine, which is a hydrophilic action. So whichever drug, additive drug you are using, what is the one important thing you have to make sure that before using them? What component should not be there in that drug? It should not have any preservative, okay, like methyl paraffin or the other disodium tartrate. All these preservatives should not be there. So all the drugs that you use should have preservative-free nature. Then only it can be used as a liquid. And with regard to description of any block, as I said, there are 4 P's. One is position of the patient. 2 is preparation of the part and your equipment and drugs, everything should be prepared. Third is the palpation, which can be by landmark technique or using your ultrasound. And fourth is the puncture, needle direction, needle insertion, the length of the needle, the click or the loss of resistance, pop feeling. These are the things which have to be described in the puncture technique. And before performing any local anesthetic block, the following protocols should be followed strictly. One is pre-anesthetic assessment, optimization, and counseling, and explaining the procedure to the patient and getting informed consent, including the alternative technique in case of block failure. All minimum monitors to be employed, and IV access is a must. And make sure all available drugs for managing either anaphylaxis or the local anesthetic systemic toxicity. Check for the availability of equipment like for airway management or cardiac resuscitation. And calculate the maximum safe dose of local anesthetic, especially in pediatric age group. Make a calculation and note it down before you start the block, and make sure that you are taking only the maximum safe dose so that you avoid excess dosage. And check for the needle for the block. Usually you prefer a not blunt needle so that you can always feel that piercing a fascia or a sheath, you can easily feel that pop feeling, and make sure your nerve stimulators are there to you can elicit a nerve contraction. And the various types of probes which you are going to use the ultrasound. So equipment check should be done, and communicating with the patient while injecting the drug. This is very, very important. This point I forgot to tell you. Though we are using smaller volumes and repeated aspiration, keep talking to the patient so that you can rule out intravascular. You can always keep conversing with the patient. They will say that I'm developing a perioral numbness or a tingling sensation. All that can be elicited, and you can immediately stop further injection. And if you are intraneural, patient will complain of severe pain. So your local anesthetic, which is supposed to block the conduction, will cause severe pain during the first few milliliters of injection into the neural inside the nerve. So all that will be found out by communicating to the patient. And of course, inject in small volumes with repeated aspiration. So, especially in areas with rich vascularity, this is a very safe technique. So, these are the 10 commands you have to remember for performing any block with the patient. And that ends at the discussion on the brachial plexus block.